Katie Heesh, and today we are coming to you from the University of North Texas Health Science Center at Fort Worth. And I have the pleasure of speaking with Dr. Meaghan Nelsen. And our topic today is where obstetrics and gynecology meets osteopathic manipulative medicine. So Dr. Nelsen, thanks so much for being here. You are muted, sorry. Thanks so much for being here. So before we jump into the questions, I am going to do a little bit of housekeeping. For those of you who are participating in today's webinar, there is some obvious participation. You can ask questions in the chat function. Feel free to type them as they come throughout the webinar, and we'll address them at the end during the Q&A section. Also, this is recorded, like I said, so it'll be posted and sent out, so don't feel like you need to jot notes down super fast. There is a recording of it. So without further ado, I want to jump right in with my first question for you, Dr. Nelsen. Would you share with us an overview of your background and training?
Absolutely. So I am not a native Texan. I apologize. I went to medical school at the New York College of Osteopathic Medicine. And while I was completing my doctoral degree, I also stayed an extra year. So medical school became 5 years for me. And I earned in tandem a master's degree in neuromusculoskeletal medicine, which is the science that underlies OMM, or osteopathic manipulative medicine. And so during that extra time, this is where I really started to fall in love with OMM and see its utility. I taught our first and second year medical students in the OMM lab, as well as in the lecture halls. But more importantly, I saw patients at our OMM clinic on campus and started to see real life use of OMM and see people get better. But I still felt called to a career in obstetrics and gynecology, women's health. And so I went on to complete an OBGYN residency at an osteopathic institution in New Jersey. And then after 7 years of traditional OBGYN, I realized that I wasn't quite doing what I was capable of doing. And so I made a slight career shift and returned to a second residency to training once again in neuromusculoskeletal medicine back in New York. Following that, I transitioned my career from purely clinical and became an academician. So that's when I started teaching at medical schools, and that's where I've been ever since, combining my two loves, getting to do a little bit of OBGYN and a little bit of OMM and putting them together.
That's so great. Well, we're happy to have you here in Texas. Welcome. Thanks for being here. So most people are familiar with the work of an OBGYN, but could you tell us more about neuromusculoskeletal medicine?
Very well done on that tongue twister.
Thank you.
Yeah, I will shorten it to NMM. Like I said previously, this is really the underlying science of osteopathic manipulation, which is the foundation of osteopathic medicine, right? That's what sets us DOs apart from our MD or allopathic colleagues. And so my job as an NMM specialist is to basically restore the body's balance and promote the self-healing mechanisms or promote homeostasis within the body. And one of our founding tenets of osteopathy is that structure and function are reciprocally interrelated. So when your body is in a place of balance, free of restrictions, it can function optimally the way it was actually designed to. And on the contrary, when there are obstructions or imbalances, your body has to work so much harder to do its normal jobs. And this is when pain, pathology, delayed healing, and suboptimal or poor functioning can actually result.
Perfect. Thank you for clearing that up for us.
Sure.
So you are dual board certified. So what sparked your desire to pursue and combine these two experiences of yours in this way?
So as a traditional OBGYN with my previous NMM experiences back in medical school, I knew how to help my patients who were suffering. I knew I could help them. I knew I had the hands to do it. But unfortunately, the demands placed on me and many of my OBGYN colleagues, nowadays, most of us are not in private practice. I was a hospital employed physician, and the way that my schedule was set up, the demands that were placed on me, they did not allow me the time in my schedule consistently to treat every patient that needed it or that I knew would benefit from OMT. And then while I was working as an OBGYN, I actually saw the problems come to a head personally. I had my first pregnancy at that time, and I worked my, traditional hours of being on call, doing surgery, manning labor and delivery until I delivered at 41 weeks. And so I have some pre-existing low back issues. And then I also suffered a common musculoskeletal change during pregnancy called a separated pubic symphysis, where the two sides of your pelvis kind of exit one side of the building one way and one the other, and they're supposed to do it uniformly together, but sometimes one goes farther than the other. And so that happened to me at 19 weeks, and I couldn't stop working. So I did the best I could. I hobbled around. I was uncomfortable. It was harder for me to do my job than it should have been. My body wasn't, functioning in an optimal capacity. And sadly, I didn't have an NMM colleague nearby to treat me. So I suffered with pain during that pregnancy and then afterwards, because I didn't get treated until about a year later when I entered that second residency. And so I knew that if there were someone like me around, a lot of these issues could have been prevented or better managed if I had had someone around to treat me with OMM. So I saw the issues in my practice, but then kind of the thing that pushed me over the edge into my new career was the fact that it happened to me personally.
Wow. Thank you for sharing that personal story. You're the definition of women can do all. So thank you for sharing that with us. So speaking of the benefits that it has for pregnant women, can you tell us about the benefits for moms and babies before, during, and after pregnancy?
Surely. So speaking about moms first, right? How not to have Dr. Nelson's pregnancy. Body, in order to be pregnant, undergoes a multitude of really magnificent changes. This is part of why I love OBGYN. I am fascinated by our physiology, how often our body gets it right and the stars align and you get pregnant and everything, comes about beautifully. But these changes that come about as a part of the physiology of pregnancy, sometimes they end up creating problems for mom that are ultimately amenable to OMT. So the most common thing that people think about is the musculoskeletal pains of pregnancy. So we treat things like low back pain, that pubic symphysis pain or separated pubic symphysis that I suffered from, but also there's carpal tunnel syndrome over the wrist, piriformis syndrome, which is in your gluteal region, as well as sciatica-like symptoms, which is actually a slight variant during pregnancy. It's something known as posterior pelvic syndrome. So in addition to all those musculoskeletal things, we also treat the less commonly thought of problems of pregnancy, like the nausea and vomiting, the headaches, the constipation, and the reflux of pregnancy. And then ultimately, if mom has had a fairly routine pregnancy, we've kind of managed these side effects of the physiologic changes and we've kept her comfortable, we've kept her moving and grooving. We work to align her musculoskeletal system and prepare her body for labor. We help encourage that natural version that happens somewhere between 32 and 36 weeks. Most babies then permanently head down so that they are prepared to be in the cephalic position for delivery rather than a breech presentation. And then postpartum, we help treat mom to encourage her body to return to its pre-pregnant musculoskeletal state. And it's really important that mom gets treated ideally in the first 6 weeks postpartum, but I will accept sometime in the first 12 weeks. And the reason why there's a time clock is because your body undergoes all of these changes secondary to a hormone called relaxin. It promotes relaxation, right? It basically makes your body loosey-goosey so that your pelvis can separate and your back can bend so that you can grow this belly out in front of you. And after delivery, that relaxin hormone very rapidly goes away. And so without that relaxin hormone, mom's body can get relatively stuck in whatever position it was left in. So if she had a really long labor, she was doing lots of pushing, maybe dad was holding one leg and he's much stronger, but the nurse was holding the other leg. So her pelvis is going to be a little bit off center, or a little bit wonky, as I call it. And that relaxin fades away before she gets treated. She will be stuck, relatively twisted. That's not how her pelvis is meant to be. That's not how she's supposed to be walking around. And I don't want her to get stuck like that, because then the treatment afterwards, it's not impossible, but it definitely becomes more challenging and more lengthy. And so once we've fixed that pelvis, we've set her on a path for healing so her body's balanced, then I move on to work with mom and baby to help support, establish, and improve that nursing relationship. So even if everything nursing at the breast is going well, or if, you know, baby is being bottle fed and that is going well, mom definitely has demands placed on her body as a new mom and has zero core strength. That is a result of your abdominal muscles separating during pregnancy, and it takes a while for them to come back together and have strength. So, you know, in medicine, and constantly we're all hearing that sitting is the new smoking, we have no core strength, and that's really what keeps your body healthy. Mom has no core strength, but has a newborn baby. She has to carry that baby in that car seat, that bucket. She's got to unfold and refold the stroller and hoist that into the trunk of the car. She's bending over at the changing table or the couch or her bed or wherever to change 12 to 14 diapers a day. And she's doing all of that without core strength. So definitely going to have some mechanical low back pain. But then when you're holding that fussy baby or you're nursing, right, she's going to bring those elbows up and out and kind of, this is a really attractive position, she spends a lot of her days like this. And so she's going to be predisposed to mechanical issues here in her neck, her upper back, those ribs in her chest, whether or not she's nursing, but it's definitely worse when mom is nursing. And then ultimately baby can struggle with latching. Baby can struggle being comfortable. A lot of times babies are born with what we call strain patterns. And it basically just means how the baby grew in the uterus, they kind of got smushed. There's not a lot of room in there. So if not every baby kind of uncurls themselves after delivery, if they decide I really like being like this and stay there all the time, it's like when you and I wake up with a crick in our neck. Mm-hmm. Oh, I can't really turn to the right. I better go get treated or put a heat pack on, something like that. Think about that baby having a crick in its neck or being stuck in this challenging position. But now that baby, in order to latch or to have a bottle, has to be able to turn their head freely and, you know, open up their arms and kind of attach to mommy's chest, and has to be able to do it on both sides in order to have a great nursing relationship. So baby can have those strain patterns that make it troublesome for them to get comfortable. It can result in some compression of the bones and nerves in their head that they actually need to use to open their mouth and establish a nice wide latch, and also coordinate that suck, swallow, breathe process. Nursing is actually really complicated for a baby, and we ask them to do it, you know, within minutes of being born. But there's a lot of coordinated activities that have to happen in the body, baby's whole body, but then also in their face, mouth, and neck in order for them to be able to do that suck, swallow, breathe, and not choke while they're nursing. So we do everything we can to remove that tension, remove those impediments to make the latching experience easier for mom and baby. But in the event that mom has a great nursing relationship, baby isn't having those issues with latching, or baby isn't nursing, we also work with some common pediatric conditions that can show up in the infant period, but then definitely in the first year of life. I've already sort of described torticollis, where you have really tight neck muscles on one side and can get kind of stuck like this. We also see a lot of babies for what's called plagiocephaly. So pre-COVID, when you were out and about and you saw people, if you ever saw, you know, at the grocery store, the little babies wearing the helmets, helmet therapy for plagiocephaly. And plagiocephaly means a flattened head. Most commonly, it's flattened in the back, but it can be a little bit off center, so the baby's head is smushed on one side or the other. And helmet therapy works to make that head look better, but I am adamantly opposed to it because I think it's preventable. This is what my research project was on during my second residency in neuromusculoskeletal medicine. If a baby has plagiocephaly, there are two concerns. One, vanity, right? You don't want them to have a funny looking egg head and get teased on the playground. But the more concerning one is a lot of times plagiocephaly doesn't happen on its own. It's seen with a combination of some torticollis or some strain patterns. And more often, the babies present with delayed motor milestones. So baby isn't rolling over, or it's only rolling one way, is late to roll, is having trouble pushing up during tummy time, getting their knees underneath them for crawling a little bit later in infancy. And so plagiocephaly treated with OMT, it works really beautifully to remove those strain patterns and kind of get to the root cause of the plagiocephaly and help make space in that head so the baby can grow into it. You ultimately do get a better looking head. But I always explain expectations to parents. Look at both mommy and daddy's heads, because that's the baby's head destiny, right? They're not going to have a model. If mommy and daddy have big noggins, the baby's going to have a big noggin.
Right.
But what's more important to me than the vanity aspect is that that baby catches up with those motor milestones. And I've seen great results with that. Rather than the helmet, which if you think about it, the helmet just smushes that head into submission. That helmet tells the head where it needs to go. Those babies have to wear helmets for 23 out of 24 hours a day. So grown-ups are struggling to wear a cotton mask right now. And we have babies in a helmet for 23 hours a day, and it's a vice grip to shove their head into a position where we want it to be. Not to mention the cost, right? So it's uncomfortable for babies. Moms, it's traumatic because they feel bad for their babies. But the cost is the average infant who requires helmet therapy, it lasts 10 to 18 months. And because of growing, they need at least 4 helmets. And helmets range between $600 to over $1,000.
Oh my goodness.
That money is spent and the baby is relatively tortured, in my opinion, with helmet therapy, when really it could just be a few office copays for some OMT across a few months, and then that baby's head could correct itself. And like I said, those delayed motor milestones can be caught up. So that's obviously one of my passion projects. And then in the older children, we work with scoliosis, right? The growing pains. Here in Texas, asthma and allergies are a year-round phenomenon. So we work with kiddos to help restore the health in their body, get their respiratory system, their facial bones, the nasal bones, the sinuses, get all of that drained and working well. And then also we work with children being treated for ADD, ADHD, anyone on or near the autism spectrum. And then just the normal aches and pains, trauma and injuries from kids being kids, whether they're athletes or not. We absolutely work with those kids as well.
Wow. Well, just listening to you speak about this, I mean, you're so passionate, so I can understand why you went this route. And I'm honestly just loving hearing you talk about it, because you think childbirth and having a baby is just a wonderful gift and it's so easy, our bodies are made for it, but you're talking us through this and there's just so many things that an average person doesn't think about. So it's amazing to hear. Before we move on, we do have 2 questions that came in regards to what we're talking about, so I want to ask them now.
Sure.
When talking about before, during, and after pregnancy, what's the normal time span that you spend with a patient cumulative? So how long do you on average see a patient for?
So it depends on what is happening. If they're coming to me for something relatively simplistic, just the aches and pains of pregnancy, for example, I tend to follow the appointment calendar that their obstetrician is using. So generally once a month, sometimes 4 to 6 weeks if they're really doing well, see them for a 20 to 30-minute treatment visit, make sure that nothing new has happened, nothing has changed, their back pain hasn't suddenly become something more severe, where neurological deficits, or I think imaging, or a consultation with another specialist is merited. Generally that's the pattern. And then as we get closer to delivery, just as they see their OB weekly at the end, they see me weekly at the end, so that we can make sure that everything in their musculoskeletal system, the soft tissues of the uterus and the pelvic floor, all the muscles that will be working to help that mom labor and ultimately deliver, making sure that those are primed and ready to go and everything's in a place of balance. Perfect.
So case by case, but on average you said about 4 to 6 weeks?
Yes.
Okay.
Unless something is more severe. If a mom presents with separated pubic symphysis, for example, so comes in at 19 weeks, that's an acute, it's really almost a traumatic shear of those bones apart. I can fix mom up pretty quickly in just one visit, but because her body has so much relaxin and ended up that way, I don't trust her body to stay in the correct place as the mechanical demands on the body are changing with that growing uterus. So a mom with something acute like that, I might see her weekly for the first 3 weeks, make sure that then her soft tissues and her bony connections are stabilized and she is feeling good, treatment is lasting for her, and then I would space out those visits.
Okay, perfect. Thank you for answering that.
Sure.
Another one we have in regards to this is, it was asked, if you don't receive treatment after an issue with your first pregnancy, is it possible to be treated effectively after a following pregnancy?
Sure. So I've definitely had patients who didn't know we existed for their first pregnancy, or maybe had a pretty easy first pregnancy, and then the second pregnancy is where they're feeling the demands, the changes of their body. And the way I explain it to patients is each time you get pregnant, your body has to expand and contract, and then it gets pregnant again to expand and contract. And it's just like if you think about our hair ties, right? Our ponytail holders, when you first pull it out of the package, it's really tight, right? You only wrap it around twice and you have a nice high pony that's really supported. Well, fast forward a month, you've been wearing that hair tie over and over every single day, and now it starts to expand, and it doesn't want to hold your hair quite so tightly.
Mm-hmm.
That happens to the ligaments, the connections in your musculoskeletal system with each successive pregnancy. And the looser things become, the harder it can become on mom, the demands of her, it becomes tougher for her to do the normal things she would do, becomes more painful for her, up and walking, caring for her other children, meeting the demands of her job, things like that. So if you didn't have issues or did have issues first pregnancy, but didn't know we existed or didn't have a doc nearby, absolutely you can see us postpartum when you're preparing, you're healing from that first pregnancy or thinking about a second pregnancy, or you show up during that second pregnancy. We have the added benefit of that relaxin hormone again. That's, surging through your system. So even if you had a difficult first pregnancy and say your pelvis got off-centered or a little bit wonky, when you come to see us, if that issue is still there, it's going to be very easy for me to treat because of the relaxin hormone. So it's not that all time is lost. If, don't do what I did. Don't do your first pregnancy without any treatment and then wait a year to start fixing your musculoskeletal issues, but it's absolutely fixable. So the best time, what is the analogy or euphemism? The best time to plant a tree was yesterday, but the second best time is today. So if you didn't happen to have an OMT expert taking care of you yesterday, then start today.
Perfect. And those analogies make it, so easy to understand. So thank you for that.
Sure.
So we are going to move down our list a little bit more. So can women who are experiencing other gynecological issues or pain benefit from OMT?
Absolutely. So we talk so much about the obstetric side of OBGYN because people tend to forget the GYN half of it. But I also work with female patients in their reproductive years up to senior citizen age who are experiencing chronic pelvic pain from a variety of issues. So one that's gaining traction now in the media is the diagnosis of endometriosis, which is really painful pelvic pain because of abnormal menstruation. Basically, I'll keep it simple. But then also anyone experiencing really painful periods, or even something called interstitial cystitis, which is the equivalent of irritable bowel syndrome, but in your bladder. So this is chronic pelvic pain, symptoms that present like a urinary tract infection or a bladder infection, but there's no bacteria there. And then I also work with our local gynecologists as well as our urogynecologists. Those are the physicians who were OBGYNs first and then did special fellowship training in the urological system of the female patient. And we care for those ladies who are suffering from painful female pelvic issues called vaginismus or vulvodynia. So pain either inside the vagina or outside on the vulva, as well as urinary and fecal incontinence. So it is not normal for anyone to be leaking anything. Whether you've had no babies, 1 baby, 5 babies, there's something that can be done for incontinence. And then post-operatively, I'm not the one performing the surgery anymore, but for my colleagues who have performed a hysterectomy or a laparoscopy where we put the camera through your belly button and do some surgery looking around. OMT, whether it's used in the hospital immediately post-operative or in the first few weeks following that surgery during the recovery period, OMT is proven to help with pain control and also restoring the bowel function. So the pain medications, the surgical procedure itself, as well as the anesthetic agents we use, to put patients to sleep, those all put your bowel to sleep. And the bowels need to wake up following surgery in order for you to be able to eat and drink, pass gas, and not have excessive pain. So I even go so far when working with these GYN patients to teach them, as well as their support persons, some home exercises or techniques, right? Because if this is dysmenorrhea, for example, they're going to have a period every month. That's not going away. It wasn't an ankle sprain that we treated and now they're cured and can carry on. This is something that's going to be routine maintenance happening monthly. So I spend some time teaching my patients and their families or loved ones some home exercises and techniques that they can utilize when symptoms arise, whether it's during their PMS or actual menstrual cycle, or if it's a flare of that interstitial cystitis we were talking about, and hopefully keep them from reaching for those unsafe and often ineffective medications.
That's super informational. And I just have to say, being a woman is fun, isn't it? So I do want to backtrack a little bit. You had talked about endometriosis. We did have a question that was submitted before today. So I want to speak to that since we're here. So the question was, can you speak about endometriosis and what you've learned, if anything, about how OMM can help women with this condition?
Absolutely. So just to put everybody on the phone call through med school and a little bit of GYN residency. Endometriosis is abnormal implants or deposits of endometrial tissue. That's the lining of your uterus. That's your womb, right? And that's what gets thick and fluffy when we get pregnant. That's what supports the placenta. But when we don't get pregnant every month, that's what is shed in the form of a period or menstruation. And so endometriosis is when somehow the coordination of the body goes awry and decides to get endometrial implants, endometrial tissue, and put it somewhere else. So most commonly, it's in the pelvis, either on the outside of the uterus, along the fallopian tubes and the ovaries, but then also it can implant on the bladder, which lives right in front of the uterus, or posteriorly at the end of your loops of bowel, right, your colon. And so these patients, endometriosis, a lot was not known about it years and years ago. And I've been fortunate enough to train during a time when endometriosis is no longer thought of as patients just being dramatic. You know, everybody has a painful period, you're just being dramatic. I think chronic pelvic pain patients with things like endometriosis and interstitial cystitis especially suffered for years. And so previous studies showed that the average time of onset of symptoms or starting to talk to your doctor and then ultimately getting a diagnosis of endometriosis or interstitial cystitis is 10 years. That's unacceptable. That's unacceptable. In my book, it's unacceptable for any other OBGYN that a patient should be needlessly suffering for that. The of endometriosis is definitely a multimodal approach. So surgery is not curative, it is diagnostic. So we will do a laparoscopy, a camera through your belly button to take a look around. We can take some of those implants out and send them to pathology to confirm our diagnosis of endometriosis. But studies have shown, sadly, that we can do surgery and clean up those implants. That does not coordinate or correlate to a better patient outcome or better pain. So there are patients on surgical on surgery, you see implants everywhere. Their pelvis looks really messy. And their symptoms are reported as mild to moderate. And you have other patients who report severe symptoms. And when you do surgery, you only see 1 or 2 implants. So it doesn't make sense. So because of all of that happens, from a treatment standpoint, we can help control the hormones involved in menstruation, because the thought is if we control menstruation, we're controlling that endometrial tissue. Mm-hmm. Because of where these implants are, because most of these patients have had at least 1 surgery, if not more, OMT works to relax everything in the pelvis. So with my hands on the outside of somebody's lower abdomen and pelvis, I can feel their female pelvic organs, and I can also feel when there is asymmetry, when there is excessive tension, when there is scar tissue. So that's a big problem, because when these endometrial implants are formed, your body realizes they shouldn't be there, and then starts to try to wall it off, tries to scar. So there can be these bands, almost like cobwebs, but they're industrial strength. Cobwebs that form between your anterior abdominal wall and your female pelvic organs and your loops of bowel or your bladder. So it can become this spider web. That's not how your body's designed, right? Your loops of bowel are supposed to be freely flowing through your belly. Your bladder is supposed to hang freely forward while your uterus hangs freely in the midline and your loops of bowel are posterior. It's not meant to be an interwoven mesh network. So with OMT, we're actually able to use techniques to soften those tissues. I can't take away the adhesion, but I can restore the normal anatomical relationship. I can calm some of the tension in those connective tissues, the same way I can calm the tension in the connective tissues of your neck when you wake up and you have a crick in it, if that makes sense.
It absolutely does, yes.
With OMM, I'm not treating the root cause. I'm not that good with my hands yet. Give me some time. I work on the symptoms for sure.
Okay, great. That makes a lot of sense, and thank you for sharing that. So the last question before we get to a few audience questions, and you kind of already spoke to this, but in case you want to elaborate, how do you work with a woman's OBGYN during pregnancy or a child's pediatrician? On average, what does that relationship look like?
Oh, it's wonderful. So without my relationships with local OBGYNs and pediatricians, I wouldn't be able to do what I do. And so when I first came to the Health Science Center a year ago, I was an unknown entity, right? I'm from out of town. So I immediately, while waiting for hospital privileges and for my practice to get busy, I went out and short of harassed people. So I met with our local OBGYNs at all the surrounding hospitals, our pediatricians, and then also connected with lactation consultants because I needed them to build my practice. So I lectured at grand rounds for both the OBGYN and pediatric departments so that these groups knew who I was, that I was here, what I was doing, and how I would help support their patients. And then in addition to having that referral base, once I established these relationships, I've designed my practice to uniquely accommodate these particular patient populations because these aren't patients who can sit and be on a waiting list for a month to be seen, right? If a mom has an acute issue during pregnancy, or if a baby was born and is struggling to latch and is not gaining weight, those patients are seen within a week. My office team has been outstanding at supporting my efforts to be both reliable as well as accommodating so that my moms and babies aren't suffering needlessly waiting to be seen, but then also so that these referring docs know that if they call me, they email me, they text me, they get my office staff, that I'm going to do everything I can to fit these patients in. I keep blocks in my schedule for emergent visits. I will put a mom and baby, first of the day, last of the day at my lunch break. It doesn't matter because I understand that these issues need to be treated acutely. And a visit with me could prevent a mom from needing or taking a potentially unsafe medicine during pregnancy, or a delay waiting to see us could mean the difference between a breastfeeding and a bottle feeding new baby, which fed is best, that's my opinion, but I know what it's like to be a mom struggling with breastfeeding. And so I know the hit that is to a mom's self-esteem when her nursing goals are not met and her hormones are all over the place in the peripartum period anyways. And I don't want that to be the case. I do not want lack of access to me to be added pain, suffering, or stress on these women and children. So I have constant, open, two-way communication with these other groups. And so far for the last year, it's been working beautifully.
That's so great. And Dr. Nelsen, your passion, it honestly makes me a little emotional because you just care so much and it's very evident. And I think that we need to see more of that because some people just think, oh, it's a job, it's an income, but you obviously are very passionate about it. So I just want to say thank you for sharing those stories and, being who you are, honestly. It's amazing.
Oh, that's so kind of you to say, but I am so, and I don't mean to cut you off, but I am so thankful and so blessed because the Health Science Center, TCOM, is the first institution to let me do what I want to do. They were so, welcoming of me with open arms and said, we will help you design this practice to look how you want it to look. And now I have a waiting list. So like there are more moms and more babies than I can possibly see. We're hiring 2 new docs who start next week in September, because once people find out about us, they spread the word. We don't have to do a lot of advertising. You know, we have a friends and family basically referral program, but I am so thankful and lucky to be able to support these moms and babies, because I can say personally, I have had 2 babies and breastfed both. And I've done 2 medical residencies. Having the babies, breastfeeding and being a mother is so much harder than 25 years of schooling, all the nights, all the weekends, all the test taking, all the boards examinations, all the hours of residency. Breastfeeding and being a mother is so much harder. It is completely joyful and has changed my life in ways I never knew I needed, and has made me the person I am, but it is really, really hard. And I don't think America does enough to support, you know, the old saying of it takes a village. I don't think we have villages anymore. So I'm happy to add one to that mom or that family's village, so that she knows she's not alone, and it is really hard. And what we see on social media are not realistic expectations, but then also that her journey with that baby is just that. It is her pregnancy, it is her journey, it is her nursing experience, it is her motherhood and her method of parenting. And she's the one who's writing that story, no one else. And so I really try to be a willing ear and a source of comfort, but then also a source of empowerment for those parents to understand that whatever they think and feel is best for their child, that's best, and no one needs to question it.
That's amazingly said. And I'm not a mother, but I would love to have you in my village. So I'm so glad that you can be doing that for other women. So thank you so much.
Oh, my pleasure.
We're going to get into audience questions. So I will do an all call at this point in time. If anybody watching has any questions, feel free to drop them in the chat. Otherwise, I do have a question that was submitted earlier. So it says, if you could pass on 2 or 3 pieces of wisdom to a mentee that wanted to follow in your footsteps, what advice would you give?
Ooh, I'm not often caught without words. So I would say be brave. I had a mentor when I called up and said, he knew, you know, it was a professor from medical school. He knew that I had liked OMM and was good at it, but that I was practicing as an OBGYN. And I said, I'm really not satisfied enough. I don't think I'm doing what I'm supposed to be doing, but nobody else is doing it. Is this weird? And he said, no, go do it. And I just needed to hear it from one person. So I love being an N of one. There was one other OBGYN and OMM expert, and she is the person who has written all the chapters and all the OMM books on women and children. Her name was Millicent T. Tamble, and unfortunately, she died before I could meet her. So I'm all alone right now. I would love to have some company in my weird little niche practice, but I think if you feel drawn to it, you go chase it. And if no one else has done it before, that's fine. You could be a trailblazer, but if you know that that's where your passion lies, I love going to work. I love what I do. I love getting to be a part of women's lives during pregnancy and just helping them. And so I want my children and I want my daughters, but also my husband too. When I leave the house, they know my mindset is not, oh, I have to go to work again. No, it's, oh, I'm going to work. I'll see you guys at dinner time, you know? So it's really important for me that I love what I'm doing every day. But then now as a mother, it's really important that my children see I choose to go to work to do something that moves me, that I feel called to, and I enjoy what I do, because I come home a better mom. I'm invigorated by what I do and then happy to switch into mom mode. So I want them to see that I'm choosing to pursue a goal, pursue a dream, live a happy life where I'm doing what I love. If I died tomorrow, I wouldn't have regrets.
And I think you're a prime example of being brave. You know, you do sound like that trailblazer, and you are doing it. And just reading the comments that people are saying, everybody thinks you're amazing. So
oh, thank you.
I'm so happy that I had the pleasure to speak with you today. We have no other questions, but I do, just on behalf of everybody and especially myself, thank you for having this conversation with us today. I feel inspired. I feel ready to go, follow my passions. So if you have any final thoughts, please feel free. But otherwise, thank you so much for being here.
Oh, thank you for having me. This was a wonderful experience. I'm a resource to anyone who thinks that they need my services or my help. I am very happy to assist in any way I can. So use my email, find me in clinic, whatever I can do to help everybody.
Absolutely. And the thank yous just keep coming in and we can't say it enough. But again, to everyone, this is recorded. I will go watch it again because I feel like it's an inspirational TED Talk. So we'll send it out, we'll post it. But otherwise, Dr. Nelsen, thank you so, so much for being here. Have a great day.
Thank you for having me, and everybody have a great day.
You too. Take care.
Bye
Bye-bye.
now.